You have been paying for Medicare your entire working life. Every single paycheck, every single year, for decades. Your FICA taxes included 1.45% for Medicare on every dollar you earned. Your employer matched another 1.45%, and if you earned above certain thresholds, you paid an additional Medicare surcharge on top of that. You paid through your W-2, you paid through your Social Security contributions. You are paying right now through your monthly Part B premium being deducted directly from your Social Security check, and you are still paying through the regular income taxes that continue to fund the program. From every possible direction, for your entire working career, you funded this system. The question is not whether you deserve to get everything out of it. You do. The question is whether the system is designed to make sure that happens automatically, or whether it is designed to make claiming your full benefits difficult enough that many people simply give up. The answer is the second one. That ends today. What follows is a complete guide to getting every dollar of Medicare coverage you have already paid for, fighting back against the denials and delays built into the system, and making absolutely certain that nothing you are owed slips away unclaimed. The $0 premium myth. What your Medicare Advantage plan actually costs. One of the most persistent and financially consequential misconceptions in the Medicare system is the belief that a $0 monthly premium on a Medicare Advantage plan means you are receiving something at no cost. You are not. You are receiving something you already paid for, being delivered through a private insurance company that is getting paid handsomely on your behalf. Here is exactly how it works. When you enroll in a Medicare Advantage plan, that insurance company submits a request to the federal government for a monthly capitation payment, a per-member per-month payment, for each person enrolled. The amount the government pays that company depends on your health status, your geographic location, and the complexity of your medical needs. For a relatively healthy person living in a lower-cost part of the country, the government is paying that insurance company approximately $500 to $700 per month on your behalf. For someone with multiple chronic conditions in a high-cost metropolitan area, that monthly government payment to the insurance company can reach $1,500, $2,000, or more. The highest payments, for very sick individuals in very expensive areas, can exceed $2,500 per month. That money comes from the FICA taxes you paid for decades, from the general tax revenues you contributed throughout your working career, and from the premium dollars being withheld from your Social Security check each month right now. The insurance company offering you a gym membership, a grocery card, and vision benefits is not being generous. They are receiving substantial government funding in your name and returning a fraction of it to you in the form of supplemental benefits. The gym membership that costs them $30 per month is funded by a $500 to $700 monthly government payment made on your behalf. You are not getting something for free. You paid for it decades ago. The only question is whether you are extracting everything you are entitled to from a plan that was bought and paid for long before you enrolled. The $2,100 Part D cap and the new automatic smoothing provision. For 2026, the annual out-of-pocket cap for Medicare Part D prescription drug spending is $2,100. Once you reach that threshold within a calendar year, you pay nothing further for covered prescription drugs through December 31st. This protection matters enormously because for years, Part D had no absolute ceiling. People with severe chronic conditions could face unlimited annual prescription costs, and many made the devastating choice to skip refills or cut pills in half simply to survive financially. That era is now over. But there is a 2026 enhancement to this cap that most enrollees do not know about, and it has real practical significance. It is called smoothing, and in 2026, it is automatic for everyone who needs it. The problem it solves is this. For people with extremely expensive medications, hitting the $2,100 cap used to happen in January or February, meaning the full annual out-of-pocket cost arrived as a massive financial shock at the very start of the year. The smoothing provision spreads that $2,100 obligation across all 12 months, rather than concentrating it in the first few weeks. Instead of owing $1,800 in January and $300 in February and nothing thereafter, The cost is distributed evenly across the year in manageable monthly amounts. If you have high-cost medications and you have not yet confirmed that smoothing is being applied to your account, contact your Part D plan directly and verify. It should be automatic in 2026, but confirming costs nothing and ensures the protection is in place. Formulary exceptions. A legal right. Almost nobody uses every Medicare Advantage plan with prescription drug coverage operates using a formulary, a list of covered medications organized into cost tiers. Most enrollees treat the formulary as fixed and final. They accept what their plan lists, take whatever alternative their plan prefers over their doctor's first choice, and pay the higher cost-sharing tier if their medication is not listed favorably. What virtually nobody is told is that you have a legal right to request a formulary exception. If a medication your doctor has prescribed is not on your formulary, or if it is listed at a tier that results in cost sharing that is inappropriate given your medical situation, you can formally request an exception. Your doctor submits documentation explaining the medical necessity of the specific drug or the specific tier placement. The plan is required to respond within defined timeframes. 72 hours for standard requests, 24 hours for urgent ones. This process exists, it is used successfully by people who know about it, and it is almost universally ignored by people who do not know it is available. Additionally, switching from 30-day retail pharmacy fills to 90-day mail-order supplies for any ongoing maintenance medication almost always reduces your per-dose cost. If you are currently filling any chronic condition medication monthly at a retail pharmacy, contact your plan's pharmacy benefit manager and ask about switching to mail order. The savings accumulate across every month of the year. Extra help. The program millions qualify for and never apply for. The Social Security Administration administers a program called Extra Help, formerly known as the Low-Income Subsidy, that provides substantial financial assistance with Part D prescription drug costs, including premiums, deductibles, and co-payments. The eligibility thresholds for this program are higher than most people expect, and millions of Medicare enrollees who believe they would not qualify actually do. The application is one of the more manageable ones at the Social Security Administration, which is notable given how complex many of their processes are. If you or anyone you know is struggling with prescription drug costs, the first call to make is to the Social Security Administration. Tell them you want to apply for extra help with prescription drug costs. They will know exactly what you are referring to and walk you through the process. Do not self-disqualify based on an assumption about income before you actually check the thresholds. Use it or lose it. The benefits that expire on December 31st. This is where thousands of dollars disappear every year for Medicare Advantage enrollees who simply do not know what they have. Medicare Advantage plans operate on a strict annual cycle. Regardless of the company name, regardless of the plan name, the specific plan you enrolled in on January 1st legally ceases to exist on December 31st at midnight. A new plan, potentially from the same company with the same name, begins January 1st. Every benefit in the prior plan expires. Nothing rolls over automatically unless the new plan specifically includes rollover provisions, and most do not. This means your dental allowance, vision benefit, hearing aid credit, fitness membership, transportation benefit, home support services, post-discharge meal allowance, grocery card, and over-the-counter allowance all expire December 31st. Any unused portion of any of these benefits is permanently lost unless you use it before year-end. Flexible benefit cards and grocery cards are a particularly significant source of lost value. A meaningful percentage of Medicare Advantage enrollees receive a card or account in the mail, set it aside without fully understanding what it is, and discover at year-end, or never, that they had hundreds of dollars in grocery or over-the-counter allowances that expired unused. If you received any card or account notification associated with your Medicare Advantage plan this year, contact your plan immediately. Find out exactly what the balance is, what it covers, whether there are category restrictions on what it can be used for, and when it expires. In 2026, these cards became harder to qualify for, and the amounts were generally reduced compared to prior years, which makes using whatever you do have even more important. Vision exams, allowances for glasses, and hearing care benefits also expire annually. Fitness memberships or gym stipends expire. Post-discharge meal programs expire. Every single benefit in your plan has an expiration date of December 31st, and the only way to avoid losing what you have already paid for is to use it before that date. The dental strategy that effectively doubles your annual coverage. If you have significant dental work needed and your plan provides an annual dental benefit, say $2,000, there is a straightforward and perfectly legal approach to effectively doubling the coverage you receive. Before December 31st, complete the portion of the dental work that fits within this year's benefit. When the plan resets January 1st and the dental benefit refreshes, complete the remaining work in the new benefit year. If you need $4,000 of dental work and your plan provides $2,000 per year, coordinating the treatment across 2 plan years means the plan contributes $4,000 total rather than $2,000. Your dentist simply splits the treatment plan, completing work on one section before year-end and the remaining section after January 1st. This requires planning conversations with your dentist now, not in December. Talk to your dental provider about your plan's benefit limit, and ask how treatment can be scheduled to use this year's benefit and next year's benefit without delay in your care. The hospital observation status trap. This is one of the most financially dangerous realities in the Medicare system, and it is entirely legal from the hospital's perspective, which makes it critical to understand before you need to act on it. When you are at a hospital, whether for 1 night, 2 nights, or 3 nights, there are 2 fundamentally different classifications for how that stay is billed. You can be formally admitted as an inpatient, or you can be classified as under observation status. From inside the hospital room, these 2 classifications are often indistinguishable. You are in a bed. You are being monitored and treated. Doctors and nurses are attending to you. You may feel certain that you have been admitted to the hospital. The financial difference between the 2 classifications is enormous. Formal inpatient admission counts toward the 3 consecutive midnight requirement for Medicare to cover a subsequent skilled nursing facility stay for rehabilitation. Observation status does not count toward that requirement, regardless of how many nights you physically spent in the hospital building. If you spend 4 days in the hospital under observation status and then transfer to a rehabilitation facility, you have not satisfied the inpatient requirement, and Medicare will not cover the skilled nursing stay. You will receive a bill that may be tens of thousands of dollars. Additionally, medications administered during an observation status stay may be billed as outpatient drugs rather than covered inpatient services, creating unexpected cost-sharing obligations you were never warned about. Every time you or a family member is hospitalized and there is any possibility of needing skilled nursing or rehabilitation care afterward, ask the doctor or hospital administrator directly and explicitly, "Am I formally admitted as an inpatient, or am I under observation status?" Ask it clearly. Ask it in writing if possible. The question is important enough to risk feeling awkward about it. The financial consequences of not asking can last for months. Fighting denied claims and prior authorization refusals. Insurance companies deny claims. Medicare Advantage plans deny prior authorization requests. This is not always a final answer, and it should never be treated as one unless you have exhausted your appeal rights. Every denial comes with legally defined appeal rights, and the appeals process has multiple escalating levels. An initial denial by the plan's automated systems can be appealed to the plan itself, then to an independent review organization contracted by Medicare, then to an administrative law judge, then to the Medicare Appeals Council, and ultimately to federal court if necessary. Most people never get past the first denial because they do not know they have the right to appeal it. Many initial denials that are appealed are overturned because many are generated by algorithms rather than by physicians actually reviewing the individual medical record. Prior authorization is one of the primary tools Medicare Advantage plans use to control costs. On Original Medicare with a Medigap supplement, your doctor's medical determination is generally sufficient to receive care. On Medicare Advantage, the plan may require its own administrative approval before covering the recommended care. effectively inserting the insurance company's judgment between your doctor's recommendation and your actual treatment. When a prior authorization request is denied, that denial is not the end of the road. Your doctor can document the medical necessity more explicitly. You can file an expedited appeal. You can request a peer-to-peer review between your doctor and the plan's medical reviewer. These processes exist, and they succeed with meaningful frequency for people who use them. Verifying your doctor is actually in network Medicare. Advantage plans operate within provider networks. Care from out-of-network providers may not be covered or may carry dramatically higher cost sharing. The complication, and it is a serious one, is that provider networks change constantly throughout the year. A doctor who was in your network when you enrolled in January may no longer be in your network by summer. A hospital that was listed as in-network on the plan directory when you signed up may have terminated its contract with the plan since then. This is not a theoretical concern. Medicare itself acknowledged a significant ghost network problem in 2025. Situations where official plan directories on Medicare.gov listed doctors as in-network when those physicians were not actually participating in the plan. The agency offered special enrollment periods to affected beneficiaries who had selected plans based on incorrect directory information. The problem is not resolved and is likely to worsen as Medicaid funding reductions force healthcare systems to renegotiate or exit plan contracts. Before scheduling any significant medical appointment, call both the provider's office and your plan to verify current in-network status. Do not rely solely on online directories. Document the confirmation with date and time. A single out-of-network service, particularly a specialist visit or a facility fee, can result in bills that far exceed anything you would have paid in-network. When you can change your plan, annual open enrollment for Medicare runs from October 15th through December 7th each year. During this period, any Medicare enrollee can switch plans, change from Medicare Advantage to Original Medicare, add or drop Part D coverage, or make other changes that take effect January 1st. This review should happen every single year without exception. Not necessarily because you need to change plans, but because the plan you are currently on is legally a different plan from the one that existed last year, and its premiums, cost sharing, formulary, and network may have changed materially since you last reviewed it. Outside of open enrollment, special enrollment periods allow plan changes under specific qualifying circumstances, including moving to a new service area, losing current coverage through no fault of your own, having your current plan exit the Medicare program, and qualifying for extra help for the first time. If any of these circumstances apply to you, you may be able to change plans before October without waiting for annual enrollment. The Social Security earnings limit for working beneficiaries. For anyone receiving Social Security retirement benefits before reaching full retirement age while continuing to work, the 2026 earnings limit is $24,480. Earnings below that threshold have no effect on your Social Security benefit. Earnings above that threshold result in a temporary benefit reduction of $1 for every $2 earned above the limit. Importantly, those withheld amounts are credited back to your record when you reach full retirement age, resulting in a higher monthly benefit going forward. The limit applies only to earned income, wages, and self-employment earnings. It does not apply to investment income, pension income, rental income, or Social Security income itself. Once you have reached your full retirement age, the earnings limit no longer applies regardless of how much you earn. Your complete action plan. The first step is to pull out your current Medicare Advantage plan documents and identify every benefit included in your plan for this year. Dental, vision, hearing, fitness, transportation, grocery card, over-the-counter allowance, home support services, post-discharge meals. All of it. Check remaining balances on each benefit. Identify which ones expire December 31st without rollover and use them before they disappear permanently. The second step is to review your prescription drug coverage completely. Confirm that the smoothing provision is applied to your account if you have high-cost medications. Request a formulary exception through your doctor if any of your prescriptions are not covered at the appropriate tier. If you are struggling with drug costs, contact the Social Security Administration and apply for extra help. The potential savings are substantial and the application is manageable. The third step is to verify that every provider you expect to see is currently in network with your plan. Call both the provider and the plan. Do not rely on the online directory. Document the confirmation. The fourth step is to understand your appeal rights thoroughly. If any claim has been denied, do not treat it as final. Request the denial in writing, understand the stated reason, and file an appeal before the deadline. If you have a prior authorization denial, your doctor can participate in a peer-to-peer review with the plan's medical reviewer. Exercise these rights before accepting a denial as the last word. The fifth step is to mark October 15th as the start of your annual plan review. Gather your medications list, your current provider list, and your anticipated healthcare needs for the coming year, so you are prepared to make a thorough plan comparison when the enrollment window opens. Use the comparison tools at Medicare.gov to evaluate alternatives side by side. The bottom line: the Medicare system is complex by design. That complexity serves the financial interests of insurance companies that benefit when benefits go unclaimed, appeals go unfiled, and enrollees do not know what they are entitled to receive. You paid for this system for decades. You are paying for it now. The only question is whether you are going to receive everything you are owed or leave it on the table, because the system made it difficult to claim. It is difficult. That is deliberate. But difficulty is not impossibility. Every strategy described here is available to you right now. Use them. If you have a specific question about your Medicare plan, your prescription coverage, a denied claim, a prior authorization dispute, a billing issue, or any other aspect of your Medicare benefits, write it in the comments. Every comment is read and responses are given. This community exists to make sure no one leaves the table without what they have already paid for. If this was useful, please share it with someone who needs it. A friend confused about their Advantage plan. A neighbor who received a denial letter and does not know what to do next. A family member who has never heard of extra help or formulary exceptions. The information here could save someone thousands of dollars. Subscribe to stay informed every time something changes with Medicare rules, plan benefits, enrollment deadlines, or legislative updates. You deserve to know when anything affects the benefits you spent a lifetime paying for. USA Claim Rights.